Welcome to the podcast series The New Student Pharmacist, where we discuss chemistry and pharmacy, as well as leaders in pharmacy careers, community, and chemistry and pharmacy research. We encourage you to support the work we are doing and follow us on Spotify and Apple Podcasts by subscribing for free. Note, the views on the podcast represent those of my guest and I.
Purpose of these episodes not at all for advice or medical suggestions. These are aimed to provide support to peer pharmacists in training in educational and intellectually stimulating ways. Again, these are not at all for medical advice or medical suggestions. Please see your local board and state-certified health professional. The views of this podcast represent those of my guests and I.
Get ready to dive deep into the world of cardiovascular pharmacotherapeutics. We've got a mountain of research and clinical guidelines here to conquer.
It's a pretty fascinating area, like this giant web, everything connected.
Yeah, it's all connected. Hypertension, arrhythmias, heart failure, blood clots, they all kind of influence each other.
Exactly. And that's why it's so important for us to understand these connections, to make, those really smart treatment decisions.
So let's start untangling this web, shall we? First up, hypertension. I think we all know the basics. Silent killer, more common than we realize, can lead to some serious complications down the road.
Right. And it's not always as simple as just, genetics and lifestyle.
Okay, so what are some of those sneaky causes that we might not always think about?
Well, you'd be surprised how many seemingly harmless things can actually nudge that blood pressure up, like certain antidepressants.
Oh, interesting.
Yeah, even some decongestants can be culprits.
Wow, okay. So it's a good reminder to always consider the whole picture, right? Like when we're looking at a patient's medication list, got to think about those potential interactions and effects.
Absolutely. A holistic approach is key.
Speaking of the big picture, the kidneys are like the MVPs of blood pressure control, right?
Oh, for sure. They're filtering waste. They're getting rid of excess fluid, but their real superpower is that RAS cascade.
Ah, the RAS cascade. Can you break that down for us?
Yeah, so basically if your blood pressure dips, those kidneys, they release renin, which sets off this whole chain reaction.
Yeah.
And that leads to vasoconstriction and sodium retention.
So it's like a built-in pressure regulating system.
Precisely.
And that's where our A to E inhibitors and ARBs come into play, right? Disrupting that cascade, helping to lower blood pressure.
Exactly. They're real game changers in managing hypertension.
But let's not forget about those sneaky hormones, especially estrogen. It can be a real wild card when it comes to blood pressure, right?
Right. Estrogen is multifaceted. It can impact the RAS system, affect how calcium behaves in blood vessels, even influences the production of other substances like endothelin-1, which is a vasoconstrictor.
So many moving parts.
Yeah, and those hormonal shifts during menopause or with oral contraceptives, those can definitely have clinical implications.
Yeah. Okay, so hormone fluctuations are definitely on our radar. Now let's talk about choosing the right thiazide diuretic. Chlorthalidone, it's potent, it's long-acting, but it comes with a higher risk of those side effects, especially electrolyte imbalances compared to hydrochlorothiazide.
That's why we can't just memorize a list of drugs.
Right.
We have to think critically about each patient, their individual needs, their risks.
Individualized therapy, always key. Okay, so imagine you've got a patient who has both diabetes and hypertension.
Ah, common scenario.
It is. What's your go-to strategy in that situation?
An ACE inhibitor or an ARB would be my top pick. Not only do they lower blood pressure, but they also offer that kidney protection, which is super important for patients with diabetes who are already at increased risk for those kidney problems.
Two birds, one stone. Love it. But what about those cases of resistant hypertension? The kind that just doesn't want to budge no matter what we do.
Resistant hypertension can definitely be challenging.
Yeah.
First, we want to maximize those lifestyle interventions. So weight loss, DHA diet, regular exercise, even prioritizing sleep, all those things can make a difference.
Lifestyle always the foundation, right?
Absolutely. But if those aren't enough, then we can consider adding a mineralocorticoid receptor antagonist like spironolactone or eplerenone,
Okay, so we've got options.
or a beta blocker if their heart rate's elevated.
Got it. So we're adding those layers as needed. Now let's shift gears to a more urgent scenario, hypertensive emergencies. We're talking organ damage here, so time is of the essence.
Absolutely. These situations require rapid blood pressure lowering, and we usually turn to intravenous medications for that.
And our go-to IV option is usually
Sodium nitroprusside.
sodium nitroprusside. But
We have to be very mindful of that potential cyanide toxicity.
right, especially with prolonged use.
Exactly. And it's especially important to monitor patients with liver or kidney issues, as they might be more susceptible to that cyanide buildup.
Okay, so it's a powerful tool, but we got to use it cautiously. Now, what about nitroglycerin? I know it's a familiar friend for angina, but how does it play a role in hypertensive crises?
So nitroglycerin mainly dilates veins, which reduces the amount of blood coming back to the heart. That, in turn, helps lower blood pressure. It's especially useful for patients with acute coronary syndromes or heart failure.
Got it. So we're choosing the right tool for the job. Labetalol, another IV option.
Right. Labetalol is a double agent.
Wait.
It blocks both alpha and beta adrenergic receptors.
Oh, what you're saying.
So it lowers the heart rate, it dilates blood vessels, and that leads to a more, pronounced drop in blood pressure.
So it's like a multitasker. Labetalol, the multitasker of antihypertensives. Okay, so we've talked about taming that hypertension beast, but what happens when those electrical signals in the heart start to go haywire? Let's talk arrhythmias.
All right, so to really understand arrhythmias, we've got to visualize the heart's electrical system.
Okay, I'm ready to visualize.
Think of it like a complex circuit board, with the SA node acting as the pacemaker.
Right, the SA node setting the rhythm.
Exactly. It sends out those electrical signals, triggering the heart to contract.
And those signals travel through the AV node and then down to the ventricle.
Right, via those Purkinje fibers. And any little hiccup along this pathway, whether it's from too much caffeine or an electrolyte imbalance or underlying heart disease, that can lead to an arrhythmia.
Okay, so any disruption in that electrical flow.
Exactly.
And when it comes to treatment, we've got this whole arsenal of antiarrhythmic drugs. But there's so many classes, it's like navigating a maze.
That's where the Vaughan Williams classification comes in handy.
Yes, the Vaughan Williams classification, our trusty guide.
It helps us make sense of these drugs,
Yeah.
It categorizes them based on their mechanisms of action.
So we can understand their effects, their potential side effects.
Right. So, for example, we have Class I agents like lidocaine, blocking sodium channels, and then Class III agents like amiodarone, primarily blocking potassium channels.
Amiodarone, the powerhouse for many arrhythmias.
It is a powerhouse.
But it's also got that long list of potential side effects.
Yeah, amiodarone can be a bit of a double-edged sword.
What do you mean?
It's incredibly effective, but it has a pretty intense side effect profile. Thyroid issues, lung problems, liver toxicity. We need to be vigilant with monitoring.
Amiodarone, the drug that keeps us on our toes.
Yeah.
Now let's talk about that big kahuna of arrhythmias, atrial fibrillation. It's like a chaotic dance party in the atria, and it can lead to some serious consequences if it's not managed properly.
Atrial fibrillation is definitely a concern, and managing it involves two main strategies, rate control and rhythm control.
Okay, break those down for us.
Rate control, we're focusing on slowing down that heart rate. And with rhythm control, the goal is to restore a normal sinus rhythm.
Got it. And the best approach depends on
The individual patient, the severity of their condition, their overall health status.
personalized medicine strikes again. And when it comes to rhythm control, we've got a couple of options: electrical cardioversion and pharmacological cardioversion.
Exactly. Electrical cardioversion uses a controlled electrical shock to, kind of reset that heart rhythm.
Like a little jolt to get things back on track.
And then we have pharmacological cardioversion, which relies on medications like butylide or flecainide to achieve that same goal.
So which approach do we choose?
Well, it depends. Electrical cardioversion is faster, but it's more invasive. Pharmacological cardioversion might be more convenient, but it might take a little longer to work. We have to weigh the risks and benefits for each patient.
Right, always considering the individual patient. Now let's talk about warfarin, the classic anticoagulant for preventing stroke in patients with atrial fibrillation.
Warfarin is effective,
It is.
but it requires careful monitoring. We have to keep an eye on those INR levels and be mindful of those potential drug interactions.
It can be a bit high maintenance.
It can. And that's why the newer DOACs like apixaban or rivaroxaban have gained popularity.
DOACs, the modern-day alternatives.
They offer similar efficacy but with less stringent monitoring and fewer interactions.
Okay, so they've simplified things a bit. Now let's shift gears to a condition that affects millions of people. Heart failure.
Heart failure, it's not just about a weak heart.
Right. It's more complex than that.
It's a syndrome where the heart just can't pump blood as effectively as it should, often due to damage from things like hypertension, coronary artery disease, even diabetes.
It's like a domino effect.
Yeah, it can lead to fluid buildup, a cascade of hormonal changes that just worsen the situation.
A vicious cycle that we need to break. So what can we do to prevent this cascade of trouble?
Preventing heart failure starts with addressing those underlying risk factors, aggressively manage hypertension, control blood sugar in diabetic patients, encourage heart-healthy lifestyle choices.
Lifestyle, always the foundation.
Always. And for those with type 2 diabetes, those SGLT2 inhibitors like dapagliflozin or empagliflozin, those have shown real promise in reducing the risk of heart failure hospitalization.
SGLT2 inhibitors, they're proving their worth. But what about those who are already facing heart failure? What's our treatment strategy?
Well, guideline-directed medical therapy, or GDMT, is our roadmap.
GDMT.
It involves a combination of medications aimed at improving heart function, reducing symptoms, and slowing the progression of the disease.
Okay, so let's break down those medication all-stars. First up, ACE inhibitors, ARBs, and RNI. They all target the RAAS system, right? So what's the difference? When do we choose one over the other?
So AC inhibitors, like lisinopril, those were the pioneers, preventing the conversion of angiotensin II to angiotensin II.
Angiotensin II, the potent vasoconstrictor.
Exactly. Then we have ARBs, like losartan. They block the action of angiotensin II directly at its receptor. And then there's ARNI, combining an ARB with a neprilysin inhibitor. It enhances those beneficial effects of natriuretic peptides.
So it's like a RAAS blocking evolution, each generation building on the previous one.
I like that analogy, a RAAS blocking evolution.
Now, where do beta blockers fit into this picture?
Beta blockers like carvedilol or metoprolol succinate are essential, especially those that are selective for beta-1 receptors.
Why is that selectivity important?
Well, it helps to minimize some of those side effects that we might see with non-selective beta blockers.
Got it. So less chance of, say, bronchospasm in patients with asthma.
I agree.
And don't forget about MRAs, SGLT2 inhibitors, even iron supplementation. They all have a role to play in optimizing heart failure management.
They do. Each one targets a different piece of the puzzle.
And the goal is to
Improve symptoms, slow progression, and ultimately improve quality of life for our patients.
Okay, final question on heart failure. HFrEF versus HFpEF. What are the key differences, and how do our treatment approaches differ?
All right, so HFrEF, heart failure with reduced ejection fraction, that's what we traditionally think of as weak heart failure.
Okay, so the heart just can't pump out enough blood.
Exactly, and that results in a low ejection fraction. Now, HFpEF, heart failure with preserved ejection fraction, is a bit more complex.
How so?
The heart muscle is stiff, making it hard for the heart to fill with blood, but the ejection fraction might look normal. Treating HFpEF often focuses on managing comorbidities like hypertension and diabetes and addressing symptoms like fluid retention.
Got it. So different types of heart failure, different strategies. Now let's move on to a condition that can be quite alarming, venous thromboembolism, or VTE. We're talking blood clots, DVTs, PEs, serious stuff.
Definitely serious. DVT, a clot that forms in a deep vein, usually in the legs, and a PE is a clot that travels to the lungs.
Okay, so both potentially life-threatening.
Absolutely.
But what sets the stage for these clots to form in the first place? Is it just sitting on a long flight?
It's more than just long flights, although that's definitely a risk factor. Virchow's triad endothelial injury, hypercoagulability, and circulatory stasis. Those are the culprits.
Virchow's triad, the trifecta of clot formation.
Exactly. Think of it as a three-pronged attack on our circulatory system.
Okay, so we're assessing our patients for these risk factors. But prevention is key, right? How do we keep those clots at bay, especially in hospitalized patients who are already at an increased risk?
For hospitalized patients, VTE prophylaxis is a must. This can include non-pharmacological measures like compression stockings, those sequential compression devices, or SCDs, and medications like heparin or enoxaparin.
So we're attacking this from multiple angles.
We have to. VTE is a serious concern, especially in those who are hospitalized or immobile.
Right, so we're being proactive. But what if a clot does form? Time to bring in the big guns, those anticoagulants.
All right, so we've got a whole arsenal of anticoagulants, each with its own personality and quirks.
Give us a rundown.
We've got heparin, enoxaparin, those we already mentioned for prevention, but they can also be used for treatment. Warfarin, the old standby, still effective but requires that careful monitoring, has a long list of interactions. And then there are the sleek DOACs.
DOACs, they've really revolutionized the world of anticoagulation, haven't they?
They have. Easier dosing, fewer interactions, no need for that routine monitoring.
What's not to love? But let's not forget about heparin. It's been around for decades. How does it work?
Heparin works by boosting our body's own natural clot fighter, antithrombin III.
So it's enhancing what our body already does.
Exactly.
And we typically give it.
Intravenously or subcutaneously.
Okay, and we monitor its effects using
The APTT test that activated partial thromboplastin time.
Right, the APTT, you gotta make sure we're keeping that clotting time within a safe and effective range.
Exactly. Safety is paramount, especially when we're dealing with anticoagulants.
Now, what about enoxaparin? It's a low molecular weight heparin, right?
Right. Enoxaparin is kind of like heparin's more predictable cousin.
Okay, I like that. More predictable. How so?
Well, it's got a longer half-life.
Ah, so it stays in the body longer.
Exactly, which allows for once or twice daily dosing. And in most cases, we don't need to monitor the APTT.
Oh, that makes things a lot easier for our patients.
It does. Fewer needles, less frequent monitoring. It's a win-win.
Now let's talk about another anticoagulant that's a bit more specialized. Fondaparinux.
Fondaparinux, it's unique in that it specifically targets factor ZAS,
Factor ZAS.
a key player in the clotting cascade.
Right, so it's a more focused approach.
Exactly. And this focused action might contribute to its lower risk of heparin-induced thrombocytopenia, or HIT.
HIT, that's a serious complication of heparin therapy, right? Can you tell us a little bit more about that?
So HIT is this rare but potentially life-threatening immune reaction to heparin.
Oh, wow.
It's a bit paradoxical because it actually causes an increase in clotting, which leads to a drop in platelet count and an increased risk of thrombosis.
So it's like the heparin backfires.
In a way, yes.
That's definitely something we need to be aware of.
Absolutely. Early recognition, prompt treatment, those are crucial. If we suspect HIT, we stop heparin immediately and switch to an alternative anticoagulant.
Like fondaparinux.
Exactly. Or a direct thrombin inhibitor.
Okay, so we've got options. Now let's shift our focus to those game-changing DOACs. They've really shaken up the world of anticoagulation.
They have, and for good reason.
So what's all the hype about?
Well, they offer a more predictable response, fewer interactions, no need for routine monitoring. They're a popular choice for both patients and clinicians.
Makes sense. So who are the key players in this DOAC lineup?
We've got dabigatran, a direct thrombin inhibitor, and then the factors acetase inhibitors, apixaban, rivaroxaban, edoxaban.
Okay, a whole team of clot busters. Let's break them down one by one. What's the deal with dabigatran?
So dabigatran directly blocks thrombin, that key player in clot formation. It's taken twice daily, and it's approved for preventing stroke in patients with atrial fibrillation, as well as treating and preventing VTE.
Sounds like a versatile option.
It is, and it's been a game changer for many patients.
What about apixaban? How does that one stand out?
Apixaban targets factors A, and it's also taken twice daily. One of its perks is that it doesn't require dose adjustments in patients with mild to moderate kidney problems.
Ah, so it simplifies things a bit.
It does.
Now, how does rivaroxaban compare?
Rivaroxaban, that's another factor in inhibitor, but it's got a slightly longer half-life, which allows for once-daily dosing for most indications.
Once daily dosing, always a plus for patient adherence.
Absolutely.
And rivaroxaban is also approved for.
A wider range of VTE-related conditions, making it a popular choice for many patients.
Rivaroxaban, the DOAC workhorse. And lastly, what about edoxaban?
Edoxaban is our once-daily hero for all indications.
Once daily, love it.
Plus, it has fewer interactions compared to some of the other DOACs.
Edoxaban, the easygoing DOAC. Now, with all these anticoagulants, bleeding is always a concern, right? We've got to be vigilant.
Absolutely. We need to monitor our patients carefully, Watch for any unusual bruising, nosebleeds, any blood in their urine or stool. Those are all red flags.
Right, and we need to be extra cautious in patients who are already at a higher risk for bleeding.
Exactly. So those with a history of falls, trauma, certain medical conditions, we need to weigh the benefits of anticoagulation against those potential risks.
Okay, so vigilance is key. Now, what about those tricky situations where we need to actually reverse the effects of anticoagulants? I know we've talked about protamine sulfate for heparin, but what about those DOACs?
Reversing DOACs can be a little more challenging. For dabigatran, we have idarucizumab. It's a specific reversal agent that binds to dabigatran and neutralizes its effects.
Okay, so that's good to know.
And for the factor XI inhibitors, there's andexanet alpha, but it's not as widely available as idarucizumab.
Okay, so we have options, but it's not quite as straightforward as with warfarin or heparin.
It's not. And that's why it's so important to carefully select patients for DOAC therapy and to thoroughly assess their risk of bleeding.
Right, we're always balancing those benefits against those potential risks. Okay, lots to consider. Now, let's move on to our final boss battle for this part of our deep dive, acute coronary syndrome, or ACS. This is where things get serious.
ACS is definitely serious business. It encompasses a range of conditions from unstable angina to those, heart-stopping heart attacks. And it all boils down to a sudden blockage of blood flow to the heart.
Okay, so a blockage, that's the common thread.
Exactly. And prompt recognition intervention, that's critical.
Let's talk about that chest pain. It's the hallmark symptom, but it's not always that classic crushing pain we see in the movies, right?
You're right. Especially in women, older adults, people with diabetes, ACS can present with atypical symptoms like shortness of breath, nausea, fatigue. Sometimes it can be really subtle.
So we've got to be really attuned to those atypical presentations, especially in those specific patient populations.
You do.
So how do we confirm if it's truly ACS? Time for some detective work.
Exactly. We use a combination of clues. Clinical presentation, ECG findings, cardiac biomarkers, chest pain that's new, worsening, doesn't respond to nitroglycerin. That's a big red flag.
Okay, so the nature of the chest pain is important.
Very important.
What about the ECG?
The ECG can show ST segment elevation, which means there's a complete blockage. Or it might show other changes suggestive of ischemia, like ST segment depression or T-wave inversions.
Okay, so we're looking for those electrical clues.
Right. And then we have the cardiac biomarkers, like troponin. Troponin that's released into the bloodstream when the heart muscle is actually damaged.
Okay, so we're gathering all this evidence.
Right. It's like piecing together a puzzle.
To confirm those suspicions. Now, let's say we have a confirmed ATHOS case. What's our plan of attack?
Speed and efficiency are key. First, stabilize the patient, provide oxygen, address the pain, and then focus on restoring blood flow to the heart as quickly as possible.
Time is muscle.
Exactly. Every minute counts.
So let's talk about those life-saving interventions. PCI, fibrinolytic therapy, CABG. When do we choose which one?
So PCI, or percutaneous coronary intervention, that's the gold standard for most ACS cases.
PCI, the gold standard.
It involves threading a catheter to the blocked artery, inflating a balloon to open it up, and often we'll place a stent to keep it open.
Okay, so it's a minimally invasive procedure, but very effective.
Very effective. Now, fibrinolytic therapy, those clot-busting medications like alteplase, that can be a lifesaver when PCI isn't readily available.
Right, so if we're in a setting where we don't have access to a cath lab.
Exactly. But it does carry a higher bleeding risk.
Right, so we have to weigh those risks and benefits carefully.
Always.
And what about CABG? That's coronary artery bypass grafting.
Right, CABG. That's a surgical procedure where we actually create a detour around the blockage using a healthy blood vessel.
So we're rerouting the blood flow.
Precisely.
And that's often reserved for
more complex cases like multivessel disease or when PCI just isn't feasible for some reason.
Okay, so we're choosing the best strategy based on the patient's individual needs and the complexity of their coronary artery blockages. Now, once that acute phase is over, what about the long-term management? How do we prevent another ACS event from happening?
Long-term management after ACS is all about secondary prevention. We want to prevent another heart attack or stroke, and that typically involves a combination of medications.
Give us the rundown.
Antiplatelet therapy, beta blockers, ACE inhibitors, statins, those are the mainstays.
Okay, so we're bringing back our familiar friends. But let's focus on antiplatelet therapy for a moment. Aspirin is a staple, right? But we also have clopidogrel, prasugrel, ticagrelor, so many options.
Aspirin is the cornerstone. It irreversibly inhibits COX-1.
COX-1, that enzyme involved in platelet aggregation.
Exactly. Now, clopidogrel, that also targets platelet aggregation, but through a different pathway, it inhibits the P2Y12 receptor.
Okay, so different mechanisms, but the same goal, prevent those platelets from sticking together.
Exactly. And then prasugrel and ticagrelor, they work similarly to clopidogrel, but they're faster acting and more potent.
So how do we decide which P2Y12 inhibitor to use? It's like choosing from a menu of clot-busting options.
The choice depends on the type of ACS, the patient's individual risk factors, the potential for bleeding.
So personalized medicine again?
Always.
What about dual antiplatelet therapy, or DAPT? When is that necessary?
DAPT that combines aspirin with a P2Y12 inhibitor, and it's standard practice after PCI. The duration of therapy depends on the type of stent that's used and the patient's individual risk factors.
So we're balancing those benefits of clot prevention against that potential risk of bleeding.
Precisely.
Now, what about the role of anticoagulants in ACS management?
Anticoagulants like heparin or enoxaparin, those are typically used during that acute phase of ACS.
Okay, so in the hospital.
Right. They help prevent further clot formation. We usually give them intravenously or subcutaneously in the hospital, and they might be continued for a short period after discharge, depending on the patient's individual risk factors.
Okay, so they're providing that extra layer of protection during those critical early days.
Exactly.
And long-term, those beta blockers and ACE inhibitors, they play a crucial role in ACS recovery, right?
They do. Beta blockers help to reduce heart rate and blood pressure, giving the heart a much-needed break. ACE inhibitors, they have those beneficial effects on the heart and blood vessels, reducing mortality, reducing that risk developing heart failure.
But they're not just treating symptoms.
Right. Yeah.
They're actually protecting the heart
Exactly.
from further damage. And let's not forget those cholesterol-lowering superstars, the statins.
Statins are essential for lowering LDL cholesterol, stabilizing plaque. They've got those anti-inflammatory effects, all of which contribute to reducing the risk of future cardiovascular events.
Statins, those tiny pills packing a powerful punch.
Okay, we've covered a ton of ground on ACS. From recognizing those sometimes tricky symptoms to implementing those life-saving interventions and establishing long-term management strategies.
It's a complex area.
It is.
But it's fascinating, and it's crucial for providing excellent patient care.
Well said. Now, before we move on to other cardiovascular conditions, there's one more concept I want to touch on, bridging therapy. What is it and when does it come into play?
So bridging therapy is like building a temporary bridge to maintain anticoagulation.
Okay, I like that analogy.
When a patient on warfarin needs to temporarily stop it, for a procedure or surgery.
Because warfarin's effects linger, we need to bridge that gap with a short-acting anticoagulant like heparin or enoxaparin, just to ensure that continuous clot protection during that vulnerable period.
So we're ensuring uninterrupted clot protection.
Got it. Okay, we've tackled a lot of challenging topics today, but there's still so much more to explore in the vast world of cardiovascular pharmacotherapeutics.
Oh, absolutely. We've just scratched the surface. It is a vast world, so much to learn, and it all comes down to making those informed decisions for our patients.
And to make those informed decisions, we need to be familiar with those tools, like the TMI risk score. Can you remind us what that's all about? Why is it so valuable, especially in managing ACS?
The TMI risk score, short for thrombolysis. In myocardial infarction, it's a way to predict a patient's risk of having a major adverse cardiac event.
Okay, so within a certain time frame.
Right, within 14 days of presenting with unstable angina or NSTEMI.
So it helps us identify those patients who are really high risk, those who might need a more aggressive approach. Exactly. It helps us stratify those patients and tailor our treatment strategies accordingly.
So what factors are we considering when we calculate this score?
Well, there are 7 different factors, each worth 1 point.
7 factors. Okay, I'm ready.
Age 65 or older, having at least 3 risk factors for coronary artery disease.
Those traditional risk factors.
Right. Hypertension, diabetes, smoking, family history.
Okay.
Known coronary artery stenosis of 50% or more, ST segment deviation on the EKG, 2 or more anginal episodes in the past 24 hours, aspirin use within the past 7 days, and elevated cardiac biomarkers.
So the higher the score,
The higher the risk.
the higher the risk, the more urgently we need to intervene.
Precisely. It's all about risk stratification.
Okay, so let's shift our focus back to those high-stakes situations, those hypertensive emergencies. We know we need to lower that blood pressure quickly, but let's dig a little deeper into those intravenous options, starting with sodium nitroprusside.
Sodium nitroprusside, it's a potent vasodilator. works quickly to lower blood pressure by relaxing the smooth muscle in blood vessels.
So it's acting directly on those blood vessels.
It is.
And it's often our first choice in those hypertensive emergencies, but...
But there's always that cyanide toxicity risk lurking in the background.
Right, it's like a powerful but unpredictable ally. We've really got to be on our toes, monitoring for any signs of cyanide toxicity, especially in patients with those liver or kidney problems, right?
Absolutely. Those patients might be more susceptible to that cyanide buildup, so we need to be extra cautious.
Okay, so sodium nitroprusside use with caution. What about nitroglycerin? We know it's a mainstay for angina, but how does it fit into the picture when we're dealing with a hypertensive crisis?
So nitroglycerin, it also relaxes those blood vessels, but it has a stronger affinity for veins.
Okay, so it's preferentially dilating the veins.
Exactly.
And what does that do in terms of blood pressure?
Well, by dilating the veins, it reduces the amount of blood returning to the heart, which ultimately lowers the blood pressure.
So it's easing that workload on the heart, which can be particularly beneficial in patients with those acute coronary syndromes or heart failure.
Exactly. It's all about matching the medication to the specific situation.
Right, the right tool for the job.
Yeah.
Okay, let's talk about labetalol, that dual-action medication that targets both blood pressure and heart rate.
Labetalol is like our 2-for-1 deal. It blocks both those alpha and beta adrenergic receptors.
So it's got a double mechanism of action.
It does, and that's what makes it so effective. It not only lowers the heart rate, but it also relaxes those blood vessels, leading to a more pronounced drop in blood pressure.
Okay, so it's our go-to when we need to control both blood pressure and heart rate, like an aortic dissection or pheochromocytoma. Now, once our patient is stable, how do we transition from those intravenous medications to those oral options? It seems like a delicate balancing act.
Smooth transitions are definitely key.
How do we make sure the transition is seamless?
Well, we typically start the oral medication while that IV infusion is still running.
Oh, I see.
And then we gradually wean off that IV drug as that oral medication takes effect. That helps to avoid those sudden drops in blood pressure that can actually cause more harm than good.
Right, we don't want to create a whole new problem by being too aggressive with that transition.
Exactly. It's all about finding that sweet spot, that balance between effectiveness and safety.
Okay, so smooth transitions are key. Now let's switch gears back to a topic that can be quite perplexing: atrial fibrillation. We've already talked about rate control and rhythm control, but I want to dig a little deeper into the pharmacological approaches to restoring that normal sinus rhythm. Let's start with a medication we haven't mentioned yet, Ibutylide.
Ibutylide, it's a class 3 antiarrhythmic that's often used for pharmacological cardioversion of recent onset atrial fibrillation.
Okay, so it's helping to convert that irregular rhythm back to a normal sinus rhythm.
Exactly.
How does it work?
It prolongs the heart muscle's refractory period, so that makes it less susceptible to those chaotic electrical signals that are driving that atrial fibrillation.
Okay, so it's like hitting the reset button on those electrical signals.
A good way to think about it.
So when would we choose Ibutylide over other options for cardioversion?
Well, Ibutylide is a good choice for patients with relatively healthy hearts, no structural heart disease, and who have had atrial fibrillation for less than 48 hours.
Okay, so recent onset atrial fibrillation.
Right. It's often given as a single intravenous dose, and it can work pretty quickly, sometimes converting that atrial fibrillation back to normal sinus rhythm within a couple of hours.
That's impressive. But like all medications, it comes with its own risks, right?
Of course. The most concerning side effect with Ibutylide is proarrhythmia.
Proarrhythmia, meaning?
It can actually trigger other arrhythmias, potentially more dangerous ones.
It was like a double-edged sword.
It can be. That's why we only administer it in a hospital setting where we can closely monitor the patient.
Right, safety first. Now, what about flecainide? It's another option for pharmacological cardioversion, correct?
Flecainide is a class IC antiarrhythmic. It blocks those sodium channels in the heart,
Okay.
essentially slowing down the conduction of those electrical impulses, helping to stabilize the rhythm and prevent those rapid, irregular contractions that we see in atrial fibrillation.
So it's another way to calm that electrical storm. When would flecainide be our go-to choice?
Flecainide is often used for patients with paroxysmal atrial fibrillation, those episodes that come and go spontaneously.
Oh, okay, so that makes sense.
And it can be given orally, generally well tolerated.
But there are certain situations where flecainide is a no-go, right?
Absolutely. We avoid it in patients with structural heart disease, like coronary artery disease or heart failure, because it can actually worsen those conditions.
Oh, wow. So it can actually be detrimental in those cases.
It can. And it's also important to avoid flecainide in patients with certain conduction abnormalities, like bundle branch blocks, because it can further impair the heart's electrical system.
Okay, so careful patient selection is essential.
It is. We have to choose our weapons wisely.
Right. The right drug for the right patient. Now let's talk about a medication that can be used for both rate control and rhythm control in atrial fibrillation, propafenone.
Propafenone, it's a bit of a hybrid. It possesses both Class IC and Class II properties.
Interesting. So it's kind of got a dual personality.
You could say that.
How does it translate into its effects on the heart?
Well, it blocks both those sodium channels and those beta-adrenergic receptors, so it slows down the heart rate and stabilizes the rhythm.
So it's like a multitasking antiarrhythmic.
Exactly.
So when would propafenone be a good option for our patients?
Propafenone can be a good choice for patients with paroxysmal atrial fibrillation, especially those who also have hypertension.
Oh, interesting. Why is that?
Because it's got those beta-blocking properties, so it can help manage both conditions.
Two birds, one stone. We love efficiency.
We do. But, like with all medications, there are precautions and contraindications with propafenone.
Okay, so what are some of the red flags?
Well, just like flecainide, we want to avoid it in patients with structural heart disease or those conduction abnormalities. And it can also interact with a lot of other medications, so we always do a thorough medication review before prescribing it.
Right. Got to be mindful of those potential drug interactions.
Wow.
Okay, one more pharmacological cardioversion option I want to touch on. Dronedarone, what's its claim to fame?
Dronedarone is another Class III antiarrhythmic, structurally similar to amiodarone.
Oh, interesting. So it's like amidarone's cousin.
You could say that, but with a slightly different side effect profile.
Okay, so what are those key differences we need to be aware of?
So while dronedarone doesn't carry that same risk of thyroid or lung toxicity as amiodarone, it does have a risk of liver damage, and it can worsen heart failure in patients with reduced ejection fraction.
Okay, so different risks to consider.
Exactly. It's all about weighing the risks and benefits for each individual patient.
Trade-offs are everywhere in medicine. Now, I want to shift gears to a medication that's been making waves in heart failure management. Those SGLT2 inhibitors. They're not just for diabetes anymore.
They're not. They've shown remarkable benefits in both preventing and treating heart failure.
And these benefits extend to
Patients with and without diabetes.
wow, so they're really expanding their reach. So how do these heart-saving superstars work? How are they achieving these benefits in the context of heart failure?
Well, SGLT2 inhibitors, they block glucose reabsorption in the kidneys, so that leads to increased glucose excretion in the urine.
Okay, so we're getting rid of more sugar in the urine.
Yeah.
But how does that translate into benefits for the heart?
Well, it has a number of positive effects.
Okay, give us the details. I'm eager to learn how these drugs are shaking up the heart failure landscape.
All right, so first, they help the body get rid of that excess fluid, which reduces the workload on the heart.
Okay, less fluid, less work for the heart makes sense.
Second, they have direct effects on the heart muscle itself, improving its function, reducing the risk of remodeling.
So they're actually protecting the heart muscle.
Exactly.
And third,
They improve the balance of certain hormones, like those beneficial natriuretic peptides.
so it's like a triple threat against heart failure.
It is.
That's impressive. Now let's talk about the practical stuff dosing. We know dapagliflozin is dosed at 10 milligrams once daily for both heart failure and kidney protection, regardless of whether the patient has diabetes. What about empagliflozin? How's that one dosed?
Empagliflozin, it's also dosed at 10 milligrams once daily for heart failure.
Okay.
But for kidney protection, the dose is 25 milligrams once daily. And it's important to note that neither dapagliflozin nor empagliflozin are recommended for patients on dialysis.
Okay, so those are important caveats to keep in mind. Now, these medications aren't completely side effect free, right? What are some of the things we need to be watching for in our patients?
So common side effects with SGLT2 inhibitors include urinary tract infections and yeast infections, which makes sense since we're increasing the amount of sugar in the urine. And we need to be cautious about dehydration, especially in patients who are already at risk, like those taking diuretics or those with kidney problems.
Right, so monitoring those electrolytes, monitoring kidney function, those are crucial.
Absolutely.
Are there any other red flags that we should have on our radar?
Well, one rare but serious complication is euglycemic diabetic ketoacidosis.
Euglycemic diabetic ketoacidosis. What's that?
It's a condition where the body starts producing ketones, even when the blood sugar isn't particularly high.
So it's a bit paradoxical.
It is. but it's something we need to be aware of, especially when we're prescribing SGLT2 inhibitors.
Okay, so what are some signs and symptoms of ketoacidosis that we should be educating our patients about?
Nausea, vomiting, abdominal pain, difficulty breathing, those are all red flags. If a patient experiences any of those, they need to seek medical attention immediately.
Got it. So watch out for those signs of ketoacidosis. Now,
Mhm.
I know a common concern with these SGLT2 inhibitors is hypoglycemia. Are these medications going to send our patients' blood sugar plummeting?
That's a valid concern, but thankfully SGLT2 inhibitors don't typically cause hypoglycemia on their own. They work independently of insulin, and they don't directly lower blood sugar like sulfonylureas or insulin.
Okay, so that's reassuring.
It is.
Yeah.
But if our patient is also on other diabetes medications,
Right.
we might need to adjust those doses to prevent hypoglycemia.
So individualized therapy, monitoring, communication, all essential. Okay, let's switch gears now to a topic that's all about clot prevention and treatment, venous thromboembolism, or VTE. We talked about the basics, but let's really dive into those medications that we use to manage these potentially life-threatening conditions. Let's start with our old friend heparin.
Heparin, the OG of anticoagulants, it's been a cornerstone for decades,
It has.
and it's still a valuable tool in our arsenal.
So how does heparin work its magic?
It enhances the activity of antithrombin III, a natural anticoagulant in our bodies.
So it's like boosting our body's own clot-fighting power.
Exactly.
And how do we administer heparin? And how do we monitor its effects?
We typically give it intravenously or subcutaneously, and we adjust the dose based on the patient's weight and the reason we're using it. We monitor its effects with the APTT test, making sure we're keeping that clotting time within a safe and effective range.
Okay, so careful monitoring is essential with heparin. Now, what about enoxaparin, that low molecular weight heparin? Is it easier to manage compared to heparin?
Enoxaparin is like heparin's more predictable cousin. It's got a longer half-life, so that allows for once or twice daily dosing. And in most cases, we don't need to routinely monitor that APTT.
Oh, so that makes things a lot simpler for our patients, and probably for us as clinicians too.
It does. Less frequent dosing, less frequent monitoring.
Now let's talk about fondaparinux, that specialized anticoagulant that specifically targets factors A.
Fondaparinux is a bit of a niche player, but it really shines in certain situations, like in patients with HIT.
Right, because it doesn't have that same risk of triggering that HIT reaction.
Exactly.
So there's a safer option for those heparin-sensitive patients. What about its dosing and monitoring?
We give fondaparinux subcutaneously once daily, adjust the dose based on the patient's weight and the reason we're using it. We don't typically monitor its effects routinely, but we do check kidney function before we start it, and we watch very closely for any signs of bleeding.
Okay, so it's a little more specialized, but it definitely has its place in our anticoagulation toolbox. Now let's shift our focus back to those game-changing DOACs. They've really revolutionized anticoagulation therapy.
DOACs have been a game changer for sure. Easier for patients, easier for clinicians.
So much easier.
Ah.
But with so many to choose from, how do we decide which DOAC is right for our patient? It's like navigating a buffet of clot-busting options.
It's a good analogy. We have to consider a lot of factors: the specific indication, the patient's risk factors, their kidney function, any potential drug interactions. It's all about finding the right fit.
Okay, so let's break down those key DOAC players. What about dabigatran? What's its story?
Dabigatran is a direct thrombin inhibitor.
Okay, so it's acting directly on thrombin.
It is. Prevents that clot formation. It's taken twice daily, and it's approved for preventing stroke in patients with atrial fibrillation, as well as treating and preventing VTE.
So another versatile option.
Very versatile.
What about apixaban? How does that one compare?
Apixaban is a factor Zagon inhibitor.
Okay, so it's working on that clotting cascade.
It is, and it's also taken twice daily. One of its advantages is that it doesn't require dose adjustments in patients with mild to moderate kidney dysfunction.
That's really helpful, especially as our patients get older.
Absolutely.
Now, how about rivaroxaban?
Rivaroxaban, that's another factor ASA inhibitor, but it has a slightly longer half-life, allowing for once daily dosing for most indications.
And once daily dosing, always a plus.
It is. And it's approved for a wider range of VTE-related conditions.
So it's a popular choice.
It is.
Rivaroxaban, the DOAC workhorse. And last but not least, what about edoxaban?
Edoxaban, our once-daily hero for all indications.
Once daily, we love to hear it.
And it has fewer interactions compared to some of the other DOACs.
Edoxaban, the easygoing DOAC. Okay, so we've talked about all the great things about DOACs, but let's not forget about the risks. Bleeding is always a concern with any anticoagulant, right?
Absolutely. We can't let our guard down. We've got to be vigilant, monitor those patients closely for any signs of bleeding, unusual bruising, nosebleeds, blood in the urine or stool.
Okay, so those are the red flags.
Those are the red flags. And we need to be extra cautious with those who are already at a higher risk for bleeding.
Right, those with a history of falls, trauma, certain medical conditions.
Exactly.
It's a careful balancing act.
It is.
Now, what about those situations where we actually need to reverse the effects of a DOAC? I know we've discussed protamine sulfate for heparin, but what are our options when it comes to DOACs?
Reversing DOACs can be trickier. For dabigatran, we have idarucizumab,
Idarucizumab, and that's a
specific reversal agent that binds to dabigatran and neutralizes its effects.
okay, so it's a direct antidote.
You could say that. And for the factor YISA inhibitors, there's andexanet alpha, but it's not as widely available as idarucizumab.
Okay, so we have options, but it's not as straightforward as with some of those other anticoagulants.
Not quite as straightforward.
So careful patient selection, thorough risk assessment. Those are really crucial when we're considering a DOAC.
They are. We're always weighing those benefits, the convenience, the efficacy against the potential risks of bleeding and those complexities of reversal, if an emergency arises.
Right, we're always thinking a few steps ahead. Okay, so much to consider with these DOACs. We've covered a ton of information about VTE, from risk factors and prevention to all those different treatment options, those reversal agents.
It's a complex area, but fascinating.
It is.
And once you understand the mechanisms, the medications, the patient-specific factors, you'll be well-equipped to make those informed decisions for your patients.
And we can't forget about the importance of patient education.
Oh, absolutely.
We need to empower our patients to understand their medications, potential side effects, what to do in case of an emergency.
Patient education is key. The more they understand, the better equipped they are to manage their condition.
Right, it's all about shared decision-making, empowering our patients to take an active role in their healthcare. Now, I want to shift gears one last time and tackle a condition that's both fascinating and challenging: chronic coronary disease, or CCD. It's kind of an umbrella term, right?
It is an umbrella term.
What all does it encompass?
It encompasses a whole range of conditions related to reduced blood flow to the heart muscle, so stable angina, coronary artery disease, even prior heart attacks all fall under that umbrella of CCD.
Okay, so it's like a spectrum of heart-related issues, all stemming from compromised blood flow.
Exactly.
So what are our key goals when we're managing CCD?
The primary goals are to reduce the risk of those future cardiovascular events like heart attacks and strokes.
Okay, so prevention.
Prevention is key. And then to improve the patient's quality of life, so managing those symptoms like chest pain and shortness of breath.
Okay, so it's about both preventing those future events and then also addressing those current symptoms.
It's a two-pronged approach.
And I imagine, like with most cardiovascular conditions, lifestyle modifications are really a cornerstone of management.
Lifestyle modifications are essential. We emphasize healthy habits like regular exercise, a heart-healthy diet, smoking cessation, and stress management techniques. Those are non-negotiables.
Those are the foundational pieces.
They are.
And of course, medications play a crucial role as well. So what are the key players in our pharmacological arsenal for CCD?
The mainstays of CCD management include antiplatelet therapy, beta blockers, ACE inhibitors, and statins.
Okay, so our familiar friends.
They are. We've discussed them in detail, but it's important to emphasize their importance in CCD as well.
Right, so we're bringing back our all-star team. But let's talk about a medication that's specifically indicated for angina nitrates. How do those work their magic to relieve that chest pain?
Nitrates like nitroglycerin and isosorbide mononitrate, they're potent vasodilators.
Because they're relaxing those blood vessels.
Exactly. They relax the smooth muscle in those blood vessels, causing them to widen, improve that blood flow.
Okay, so we're improving blood flow to the heart muscle.
Precisely. And they have a particular affinity for veins.
Oh, interesting. So they're preferentially dilating those veins.
They are, which reduces the amount of blood returning to the heart, and that decreases the workload on the heart and improves oxygen supply to that heart muscle.
Okay, so it's like they're giving the heart a little bit of a break.
Exactly, taking some of the pressure off.
Now, how do we typically administer nitrates for angina? Are there different formulations for different situations?
There are. For acute angina attacks, sublingual nitroglycerin is our go-to.
Sublingual, so under the tongue.
Exactly. It's rapidly absorbed, provides quick relief from that chest pain. And for long-term management, we can use oral or topical nitrates like isosorbide mononitrate or those nitroglycerin patches to prevent those angina episodes.
Okay, so different formulations for different purposes.
Yeah.
But we've talked about how long-term nitrate use can lead to tolerance.
Nitrate tolerance, that's a common issue.
What is that all about?
Well, basically, the body becomes less responsive to the effects of nitrates over time. And this happens with continuous exposure to nitrates, especially with those long-acting formulations like patches.
So the magic starts to fade.
It can, but we have strategies to prevent or at least manage that tolerance.
Like
The most effective strategy is to make sure there's a nitrate-free period each day.
a nitrate holiday.
Exactly. Typically 8 to 12 hours. That allows the body to kind of reset and regain its sensitivity to those nitrates, so they're more effective when they're needed.
Okay, so give those nitrates a break. Now let's talk about a medication that's sometimes used for refractory angina.
Refractory angina, that's angina that doesn't respond well to those other treatments.
Right, so those stubborn cases. And the medication we're talking about is
Ranolazine.
ranolazine. How does that one work? Is it similar to nitrates?
Ranolazine is unique. It works by inhibiting a specific current in the heart muscle cells called the late sodium current. And this helps to reduce calcium overload in those heart cells, which can improve myocardial relaxation and blood flow.
Okay, so it's working a little differently than those nitrates.
It is. It's got its own unique mechanism of action.
So when would we choose ranolazine for our patients? Who are the ideal candidates?
Ranolazine, it can be added to other antianginal medications like beta blockers and nitrates in patients with chronic stable angina who haven't really achieved adequate symptom control with those other medications. So it's not for those acute angina attacks, it's for long-term prevention.
Got it. It's like an add-on therapy for those stubborn angina cases.
Exactly.
Now, what about side effects? Any we should be watching for?
The most common side effects are dizziness, headache, constipation, and nausea. And it can also prolong the QT interval on the EKG.
The QT interval, that's a measure of
The heart's electrical recharging time.
prolonging that can.
Increase the risk of certain arrhythmias. So it's really important to monitor the QT interval, especially when we're starting ranolazine or adjusting that dose.
Okay, safety first. Now, before we wrap up this epic deep dive into cardiovascular pharmacotherapeutics, I want to emphasize one key point. Individualized therapy.
Couldn't agree more.
What works for one patient might not work for another.
Absolutely. There's no one-size-fits-all approach in cardiovascular medicine.
We have to consider each patient's unique situation, comorbidities, risk factors, their preferences, even their lifestyle when making these treatment decisions.
It's like putting together a complex puzzle. All these pieces we have to take into account to really create that personalized treatment plan.
And that's where our expertise as pharmacists comes in.
Absolutely. We need to understand the medications, the mechanisms, the interactions, the side effects, the monitoring parameters. We need to be excellent communicators, educators, advocates for our patients.
So it's about more than just dispensing medications.
It is.
We're partners in their healthcare journey.
We are, empowering them to take control of their heart health and live their best lives.
Well said. We've covered an incredible amount of information today, but remember, this deep dive is just the beginning. Keep those brains engaged, keep learning, keep asking questions, and you'll be well on your way to becoming those cardiovascular pharmacotherapy rock stars. And to our listeners, thanks for joining us on this epic journey. We'll catch you next time on The Deep Dive.
Individualized therapy, it really is the foundation of effective cardiovascular care. We have to recognize that every patient is unique, their situation is unique, and we can't just have this cookie-cutter approach.
Absolutely. We can't just, pull out our protocol and apply it to everyone.
Right, exactly. We have to tailor our treatment strategies to those specific needs, those individual circumstances.
So speaking of tailoring treatment strategies, let's dive into the world of acute coronary syndrome, or ACS. This is where things can get, really intense in the clinical setting, right? Those high-stakes situations.
Absolutely. ACS is a spectrum unstable angina to, those heart-stopping heart attacks.
Right, a spectrum of conditions, but all stemming from
a sudden blockage of blood flow to that heart muscle.
a blockage that's the common denominator.
It is. And time is muscle when it comes to ACS. We've got to act quickly to restore that blood flow and minimize that damage.
Every minute counts.
Every minute counts. That's why it's so critical to recognize it quickly and then intervene appropriately.
So let's talk about those warning signs, those ACS red flags. Chest pain, I think that's the classic symptom that everyone thinks of, but it's not always that textbook crushing pain.
Right, not always like what we see in the movies.
Not always. So what are some of those less obvious presentations, those atypical symptoms that we need to be aware of?
Well, especially in women, older adults, people with diabetes, ACS can present with atypical symptoms, shortness of breath, nausea, even just fatigue.
Fatigue, wow, okay.
Yeah, it can be really subtle, and that's why we have to be so vigilant. We can't afford to miss those clues.
So we're really keeping our diagnostic radar on high alert.
Yeah.
But how do we confirm if it's truly ACS? We've got our suspicions based on the presentation, but we need to, gather some evidence. What tools do we have?
It's like piecing together a puzzle. We use a combination of clues, clinical presentation, ECG findings, cardiac biomarkers.
Okay, so break those down for us.
All right, so the chest pain itself, if it's new, if it's worsening, if it doesn't respond to nitroglycerin, that's major red flag. Then we look at the ECG that can show ST segment elevation, which means there is a complete blockage. Or it might show those changes that suggest ischemia, like ST segment depression or T-wave inversions.
So looking for those electrical clues.
Exactly. And then we have those cardiac biomarkers, those telltale signs of troponin. It's released into the bloodstream when heart muscle is damaged.
Okay, so we're putting all those pieces together, building our case.
Exactly.
Now, let's say we have a confirmed ACS case. We've got all our evidence. What's the plan of attack? How do we restore blood flow and minimize that damage to the heart?
Speed and efficiency, those are paramount. First, we need to stabilize the patient, make sure they're getting oxygen, address that pain, and then we have to choose the most appropriate reperfusion strategy.
Okay, so reperfusion, we're talking about restoring that blood flow.
Exactly.
So let's talk about those options. PCI, fibrinolytic therapy, CABG. When do we choose which one? What are some of those factors that guide our decision-making?
All right, so PCI, percutaneous coronary intervention, that's the gold standard for most ACS cases. It's minimally invasive. We thread a catheter to that blocked artery, inflate a balloon to open it up, and oftentimes we'll place a stent to keep it open.
So it's like a plumbing job for the heart.
I like that analogy.
Minimally invasive, but very effective.
Very effective. Now, fibrinolytic therapy, you might hear it called clot-busting therapy.
Right, the clot busters.
Exactly. It uses medications like alteplase to dissolve that clot. It can be a real lifesaver when PCI isn't an option, like if we're in a rural area.
Right, or if the patient's just not stable enough to transport to a cath lab.
Exactly.
Yeah.
But it does carry a higher risk of bleeding complications.
Right, so that's a trade-off we have to consider.
Always weighing those risks and benefits.
And what about CABG, that coronary artery bypass grafting surgery?
Yeah.
When is that the best option?
CABG, that's a more invasive procedure where we actually create a detour around that blockage using a healthy blood vessel. We often reserve that for more complex cases like multivessel disease or when PCI just isn't feasible for some reason.
Okay, so it's a more involved surgery, but sometimes it's the best option.
It is, and sometimes it's the only option.
So we're choosing the best strategy based on each patient's individual needs, the anatomy of their coronary arteries, the severity of their blockage. So many factors to consider.
A lot of moving pieces.
It is. Now, once we've addressed that acute situation, the patient's stable, they're recovering, what about the long game? What about preventing another ACS event from happening?
That's where secondary prevention comes in.
Secondary prevention, so preventing a second heart attack or stroke.
Exactly, and that typically involves a combination of things, lifestyle modifications, of course, and then those targeted medications.
Okay, so let's break down those key components of secondary prevention, starting with those lifestyle changes. What are the non-negotiables for our ACS patients?
We really hammer home those heart-healthy habits. Regular exercise, that's a must. A balanced diet, low in saturated and trans fats, absolutely essential. Smoking cessation, if they're still smoking, we need to help them quit. And then stress management, finding healthy ways to cope with stress.
So it's not just about medications.
No, it's a whole lifestyle overhaul.
It's about making those long-term changes to support that heart health.
Exactly. And those lifestyle changes aren't just recommendations. They're essential for reducing that risk of another event.
Lifestyle modifications, they're not just for primary prevention, they're crucial for that long-term management after an ACS event as well. Now, let's talk about those medications that play such a big role in secondary prevention. What are our go-to agents for these ACS patients?
The mainstays, antiplatelet therapy, beta blockers, ACE inhibitors, statins, those are our all-star players.
Okay, so we're bringing back our familiar friends.
We are, and we've already discussed these medications in quite a bit of detail, but it's worth reiterating their importance in this context, in this secondary prevention setting.
Absolutely. So let's delve a little deeper into antiplatelet therapy. Aspirin, we know that's a cornerstone.
Aspirin is our foundation.
But we also have those P2Y12 inhibitors, clopidogrel, prasugrel, ticagrelor. So many options. It's hard to keep them all straight sometimes.
It can be. So let's break it down. Aspirin, it irreversibly inhibits KEOX1.
KEOX1, that enzyme involved in platelet aggregation.
Exactly. It's preventing those platelets from sticking together, forming those clots. Now, the PTY12 inhibitors, they also target platelet aggregation, but through a different pathway.
Okay, so a different mechanism, but the same end goal.
Same end goal, preventing those clots. Clopidogrel inhibits that P2Y12 receptor.
Yeah.
Now, prasugrel and ticagrelor, they also work on the P2Y12 receptor, but they're faster acting, more potent than clopidogrel.
So how do we choose? How do we decide which P2Y12 inhibitor is the best fit for a particular patient?
It's a good question. We have to consider the type of ACS, the patient's individual risk factors, their potential for bleeding. It's individualized medicine every time.
Right. Personalized medicine is always the goal. What about dual antiplatelet therapy, or DAPT? We hear that term a lot. When is that a necessary part of our strategy?
DAPT that combines aspirin with a P2Y12 inhibitor, and it's standard practice after PCI, after those stent placements.
Okay, so after a PCI.
Exactly. And the duration of that DAPT, it really depends on the type of stent that's used, the patient's individual risk factors. Again, it's all about that risk-benefit assessment.
Right, we're always balancing the benefits of preventing clots with that potential risk of bleeding complications.
We are.
Now, what about the role of those other medications, those beta blockers, those ACE inhibitors? How do they contribute to that secondary prevention picture?
Beta blockers, they're helping to reduce that heart rate, reduce blood pressure, really giving the heart a break, allowing it to recover. And those ACE inhibitors, they have so many benefits. They reduce blood pressure, they improve blood flow, and they even prevent those harmful structural changes that can happen to the heart after an ACS event.
Wow. So they're not just treating symptoms, they're actually protecting the heart from further damage.
Exactly. They're modifying the course of the disease.
And let's not forget about our cholesterol-lowering powerhouses, statins.
Statins, they're essential. Lowering that LDL cholesterol, stabilizing plaque, they've got those anti-inflammatory effects. All of those things work together to create a healthier cardiovascular system, reduce that risk of future events.
Statins, small but mighty. Okay, we've covered so much ground on ACS, from recognizing those sometimes really subtle warning signs to implementing those life-saving interventions and establishing those long-term management strategies. It's a lot to take in.
It is. It's a complex area, but it's so important to have a deep understanding of these concepts because it's how we provide the best possible care for our patients.
Absolutely. What I said, we've explored so many different cardiovascular conditions and their treatments, hypertension, arrhythmias, heart failure, those clot-related challenges, and it all comes back to those core principles.
Individualized therapy, patient education, a holistic approach. Those are the foundations of cardiovascular care.
We can't just memorize lists of drugs. We have to really understand the mechanisms, the nuances, those potential benefits and risks, and then apply all that knowledge to each unique patient.
And we need to be more than just dispensers of medications.
Right.
We're educators, counselors, advocates for our patients. We're empowering them to take control of their heart health and live their best lives.
We're partners in their healthcare journey.
Yeah.
And to our listeners, thank you for joining us on this incredible adventure through the world of cardiovascular pharmacotherapeutics. Keep those brains engaged, keep learning, keep those questions coming, and we'll see you next time on The Deep Dive.
Purpose of these episodes not at all for advice or medical suggestions. These are aimed to provide support to peer pharmacists in training in educational and intellectually stimulating ways. Again, these are not at all for medical advice or medical suggestions. Please see your local board and state-certified health professional. The views of this podcast represent those of my guests and I.
Thanks for listening to the podcast series The New Student Pharmacist, where we discuss chemistry and pharmacy, as well as leaders in pharmacy careers, community, and chemistry and pharmacy research. We encourage you to support the work we are doing and follow us on Spotify and Apple Podcasts by subscribing for free. We are so glad that you were able to tune in today. Note, the views on the podcast represent those of my guest, and I take care and all the best.